absolutely delighted to have Dr. Michael Fiore be our special medical rounds guest speaker. Dr. Fiore has led our nation's efforts to improve public health by reducing tobacco use for nearly 3 decades through research, outreach, public health advocacy, and educational contributions that have influenced nearly every healthcare professional in Wisconsin and in the US. And just a little bit of background, he was raised in Boston and was the first graduate of his inner city high school to attend medical school since World War II. He completed his internal medicine residency at Boston City Hospital, and after completing his training, he went on to join the CDC as an epidemic intelligence service officer. And then after completion of that, joined the UW Department of Medicine in 1988. He took a bit of a break once he joined the reserves and was actually on active duty in the first Persian Gulf War and stationed in Germany, which was the main hospital for receiving the Gulf War casualties. After honorably discharged from the Army, he returned to UW. And in 1992, he founded and has continuously directed the UW Center for Tobacco Research and Intervention, or CTRI. And during that time, he really has masterfully married the power of science with its potential to advance public health and public policy. He's been so influential nationally, including serving as senior advisor for the tobacco cessation policy issues for the NCI, National Cancer Institute, and is currently serving as senior scientist on the Cancer Center Cessation Initiative for the NCI Moonshot program. And if I had to list all of the numerous leadership awards, leadership roles, honors, and awards, we would never get to Michael's talk. But I will highlight his election to the National Academy of Medicine, and of course, the most recent UW Hilldale Award. Recently, the NCI asked Dr. Fiore to lead a national initiative to examine discrete EHR data on newly diagnosed COVID patients at 21 health systems across the nation. Really, it's probably the largest trove of such data in the world. And he's going to be telling us about his experience doing that. And with that, I will say it's probably not unreasonable to say that no physician alive today has had a greater impact on the health of people living in the United States than Dr. Fiore. So I am delighted to introduce Dr. Michael Fiore.
Well, and thank you so much for that incredibly kind and generous introduction. You're right, this morning I'm going to be talking about CEC-UW, which is an initiative that began with COVID, and I think is another example of how the University of Wisconsin is viewed as a go-to center to make things happen in both clinical medicine and public health. So I'm really pleased to have this as the very first description of this initiative. And I'm just going to highlight that what I'm going to describe today is our preliminary look at where we are. So with that caveat, I'm going to click here and show you that slide. Here is our title slide. And I have no conflicts of interest to declare. And here's an outline of what I'm going to do over the next 40 minutes or so. I'm going to describe the goal of the project, some of the fundamentals about it, preliminary findings, and I'm going to talk about both across the whole cohort of over 600,000 COVID patients, but I'm going to really zero in on data from UW Health. So for all of you who are treating COVID patients, you'll have a taste of what we've observed. And thank you so much, all of the UW Health IT team, in particularly Oliver Enck, who's worked tirelessly to deliver data in a timely way. I'm going to talk about plans and next steps and finally end with some thoughts on trials and tribulations about taking on an EHR cohort of this size. So first, project goals. The National Cancer Institute, as did so many other entities at the launch of COVID, was faced with, how do we deal with this disease? What can we do to help clinicians understand what's happening to the patients who develop COVID? And of course, one extraordinary opportunity to do that is to examine electronic health record data. One incredible challenge of examining electronic health record data is that it's so hard to harmonize such data across health systems, even if they have the same platform such as Epic. As you'll see in a second, we have some experience with this, and NCI turned to Wisconsin and said, can you give this a try? And could you do it yesterday? Basically, the goal was to determine if a broad array of discrete EHR data elements, including smoking and cancer history, but much more than that, are related to COVID severity and outcomes. Some of the fundamentals. Well, building on the expertise at CTRI and the Department of Medicine and UW. We have expertise in tobacco control and cancer prevention. We have a lot of history working with EHR technology, and our colleagues at Epic have been wonderful to work with now for more than 20 years. And as Lynn mentioned, the UW Comprehensive Cancer Center serves as the coordinating center of a large moonshot initiative. Betsy Rowland, Dr. Betsy Rowland is the PI of that initiative. We've done that collaboratively with the UW-CCC, another wonderful example of cross campus and department and med school collaboration. But the important point about the NCI's Cancer Center Cessation Initiative, which we refer to as CTRI, is it involves 52 health systems across America, as well as their electronic health record technology. So in April 2020, NCI asked if we would take this on. And they asked us if we would identify health systems across America that had large numbers of COVID patients. The health systems had to agree to share all of their EHR data from all of their COVID patients. So I want to really emphasize that, not just the cancer patients with COVID. And almost immediately, 21 health systems agreed to participate. Here's a map showing where those health systems are located, and the names of the systems in the bottom left. Those systems span the nation, but they also span waves of the pandemic. We have a bunch of them in the New York City area, so that the first wave back in February, March, and April of 2020 is there. The Midwest wave, when we saw a lot of cases in the Midwest in the summertime, and then in the fall when it moved to the West. So this gives us some of the breadth and depth of the pandemic, and we're collecting EHR data from all of these sites. I need to give a giant shout out. This is an incredible team that came together essentially overnight. I'm not going to name everyone, but every one of them are essential. And if anybody's not on this list, my apologies. Wonderful people who dropped a lot of their work to help to do this as quickly as we could. One essential component of defining a cohort is to define the case for that cohort, so that we would be able to tell the health systems what they need to go in and pull out the specific patients. So this is our case definition for when we initially started the project. It is any of the three of these criteria. First, a positive COVID PCR test. Secondly, a diagnostic code for COVID, an ICD-10 code, or a COVID-19 antibody test. So again, if the patient had any of these, and many of them, of course, had multiple of these, they were part of the cohort. NCI has asked us to continue this into 2021, and one of the characteristics of this project is that we evolve over time in response to the pandemic. So what we have done is expand the case definition to include two additional factors. First, the now availability of rapid COVID-19 tests. If that was positive, you get into the cohort. And finally, a positive test for COVID-19 antigen. So currently, any of these 5 criteria lead an individual to be part of the cohort. A little bit about the project timeline. We spent from April to June launching, and I'll go into some of those launch details in just a moment. We initiated data extraction starting in July, and as you'll see, we asked the 21 health systems to send us their data on a monthly basis so that it would be continuously updated. We began to extract the data and analyze it in October, and we made a substantial transformation in January of 2021. NCI asked us to continue and expand the cohort through this new year. We agreed to do that, but we realized that our initial IRB designation of a totally IRB exempt data set was limiting us. So we transformed it, redid all of the IRBs, redid all of the data transfer and use agreements with the 21 sites, and we now have a limited data set, and I'll talk about that in a couple of minutes. So don't have to worry about the details of this slide. I want you to see, though, 2 points to take away. First, data is extracted on a monthly basis. On the first of each month, we ask the 21 sites to send us their data. Every patient has a 64-digit de-identified code. And the second point to note is that every month that they send us data, they do a look back to the start of the cohort, which was February 1st of 2020. We attempted to get right from the beginning of the pandemic. And as you can see, we collected data on a monthly basis throughout 2020. And in 2021, we're moving to quarterly data submissions. I mentioned a moment ago that each patient has a 64-digit de-identified identifier. One of the really strong pluses of this cohort is that we're collecting longitudinal data on every participant, so that if they return, they developed COVID in December of 2020 and were hospitalized for that. If they return to the same hospital in February of 2021, because with the look back periods, we'll collect that longitudinal data. So it's going to be a data set that will allow us to examine long COVID or the syndrome of people continuing with symptoms after they develop COVID. So here's some key project milestones in terms of launch. We had to quickly secure participation and input from the 21 health systems. We obtained UW IRB approval as an exempt project. That was great. Everything's de-identified. the 64-digit identifier that I mentioned. This allows us to track for post-initial COVID diagnoses. And importantly, the patient has to return to the same health system. But if they do everything that happens, inpatient, outpatient, COVID-related care, non-COVID-related care, all of that is captured. The sites de-identify the data before they send it to us. We have data transfer and use agreements. We hired an EHR consultant, Blue Tree, that has been just fantastic, a full partner in every part of this initiative. And then we identified about 195 discrete EHR data elements that I'll show you in just a moment that allow us to dig deep into what characteristics of patients are associated with outcomes like death, intubation, rehospitalization, etc. So that is the core of this. Identify a series of discrete EHR data elements, pull them from each COVID patient in the sample, and then see if those data elements are associated with outcomes. Let me share with you some of the data elements from the 195 that we're collecting. There are, in fact, 4 categories of data that we're collecting from every patient. Patient level data for each of the encounters, the medications the patient is on, the lab tests that occurred. Importantly, we don't just download the whole EHR. Rather, we tell the health systems, these are the 195 data elements, go in and find them. And as you might expect for many data elements, it's a refining process over time. I'll give one example. Something as simple as death, we thought would be very easy to code from the EHR. If the patient dies in a hospital, that should be very straightforward. We've now identified more than 200 different ways that the 21 health systems code death. And once we find a new way that one system did it, we then go back to the other systems and say, wait a second, we found another way to document death. Could you add that to your coding so that we're able to ensure that we capture as complete a data set as possible, knowing that this is real world data and it's never going to be perfect. So one important question is, how did we select these 195 data elements? Well, it was through a variety of processes, but the core part was what made sense in terms of determining outcomes such as death or intubation or rehospitalization or chronic disease, as well as what the literature was telling us. So we tracked the literature. We now have a data set of almost 1,000 COVID articles. We pull out the signals that say, you know, you really should begin thinking about platelet count. So that got added as a data element. And we've done that for scores of additional data elements over time. So here's looking at some of the patient-specific data that we collect, the usual demographics, but including insurance status, BMI, blood type. We look at past comorbid conditions, and we do a 3-year look back for all of these conditions. And it's really important because we wanted to know, for example, the degree to which renal insufficiency or being on dialysis predicted outcomes as one example. So a 3-year look back of prior conditions. What about data that we collected on the encounter? I want to emphasize this first point. We collect data not just on hospital visits, but for every visit in which the patient met one of the COVID inclusion criteria. So we have data on inpatients, office visit equivalents, emergency department, primary care. We even have data if the patient just went through a UW Health, for example, drive-by testing site and they were positive. The implications of this, of course, is that the amount of data we have on each patient varies enormously. For inpatients, for example, we have pretty complete data. If you're a resident of Madison, though, and you went to a drive-by UW Health testing site, and you had never been to UW Health before, but you're COVID positive, you get in our sample. But when we look in your data set, virtually every field is empty. Another example of real world data, but we collect oxygen needs, signs and symptoms, intubation, septic shock, smoking status, and also look at the current comorbid condition. So if they're diagnosed in hospital or in the primary care clinic with hypertension during that encounter, we collect that too. What about medications? The ones you'd expect, we're, as CTRI, particularly interested in cessation medicines, but we looked at blood thinners, steroids, blood pressure, COVID medicines, the complete array of them, and we add them as they get approved for COVID, and COPD meds. For medications, we do a 1-year look back. So for example, we'd want to know if a person was on steroids in the last year as a predictor for outcomes. This again is something that we update on a regular basis. And finally, lab tests. Obviously, we have the lab tests that are related to COVID, but other ones that we've all heard about as possibly related to COVID outcomes. And the lab tests do not look back. They're from the point at which the patient was diagnosed with COVID, with one exception, and that's hemoglobin A1C that we use as a surrogate for a diagnosis of diabetes if it is above the level of normal. So a little bit about the 195 data elements, but we had a chance at the beginning of 2021 to expand that list based upon our experience in our transformation of the data set from a entirely de-identified data set to a limited data set. So we now are able to get 5-digit zip code information, incredibly important because it allows us to get into some of the geodeterminants of health. With a de-identified data set, you can only look at the state level. The index state, one thing about de-identified data sets is you can't have any dates. So we're not able to look at the differences between early and later in the epidemic. Now that we have a limited data set, we can do that. We want to collect information on vaccine. We're really interested in seeing the course of patients who were and were not vaccinated. We're looking at diagnoses in great detail. In general, we're collecting diagnoses, but we're also collecting MISC, that syndrome for children. And we're looking at discharge disposition, which we weren't doing before. What happens to the patient after they leave the hospital? And we've, of course, added some of the new COVID medicines that are come available and are being used, as well as a couple new COVID labs. All right, so I want to take a minute and talk about some of the strengths and weaknesses of this cohort, and then I'm going to turn to some of the results. So some of the strengths, an incredibly large and varied sample. Right now, we have 626,000 COVID patients in our sample. Of those, 85,000 had their first COVID hospitalization, for which we're really zeroing in on detail because we want to see what happens when a patient is diagnosed with COVID and their outcomes if hospitalized. Lynn mentioned this might be the biggest one in the world. It's the second biggest cohort in the world that we're aware of. There's a second NIH cohort that has about 1 million patients, but we're adding, and we'll see if we catch up to them at some point. As I mentioned, 21 health systems. They were from across the nation geographically, but they also have incredibly diverse populations. So really able, because of the sample size, to look at things as specific as Native Americans. We have thousands of Native Americans. This is going to provide an opportunity to examine issues around populations who in the past could not be examined because of sample size limitations. Longitudinal data. We go back to February 1st, 2020, every time we do a data poll, and we make sure that among those 626,000 patients, if they got additional care, inpatient or outpatient, we capture those results. And that is a really powerful component of the data set. We have this extensive array of EHR data elements that I shared. We go retrospective, as I mentioned, to February 1st, 2020, every time we do a data poll, and this allows us to refine both the data elements and the coding for those elements so that we get particularly complete data sets for every patient. And we add data elements with essentially every data poll, whether it's monthly or now quarterly. And one really important aspect of this from a scientific perspective is that we're going to be able to look at questions that have already been asked and in some instances examined, but with more patients. One key part of science is to make sure the earliest findings continue to be relevant when we're advancing in the pandemic. All right, this data set has enormous limitations as well, and I want to highlight those. First, it's limited to individuals diagnosed with COVID. So we're unable to examine risk factors for COVID. You don't get into the sample unless you have been diagnosed with COVID. We have discrete data elements for the most part, not exclusively, but for the most part. What this means is that if there's a data element that we haven't thought of and included in the 220 that are currently in our sample, we won't be able to determine if that predicts outcomes. Moreover, while we look at some text fields, there are many text fields that we miss. If a doctor, for example, documents some key predictive component of that patient's hospitalization, but does not put it in a discrete place, we will not get it. An example of a text note that says the patient's blood pressure for a brief period of time went up to 280 systolic, but that was not documented. Hard to imagine a doctor would not do that, but nevertheless would miss it if it wasn't in the blood pressure field. Missing data, as I mentioned earlier, a big challenge because every field in every EHR is not complete. Much as we'd love it to be, it's not. E-cigarettes, a great example. We're missing e-cigarette data on 70% of the patients. So what that means for us is that we really can't predict the links between e-cigarettes and outcomes. We have a very limited sample that has e-cigarette data. We don't have any controls. So it would have been, in the ideal, wonderful to collect one control for every COVID patient, controlling who doesn't have COVID, but controlling for some key demographics on that patient. Something that would be a big lift to do at this point, and we probably won't be able to. But the other NCI data set that has 1 million patients has 2 controls for each of them. So we'll be able to lean on, and we're collaborating with that other data set, by the way, to use that information. Other limitations, and this is a giant statistical challenge, but it's a real world reality. When you look at Mount Sinai in Manhattan, in March of 2020, when they had patients in the hallways unable to be treated, the outcomes of the patients in Mount Sinai during that time are markedly different than UCSF in California, which had their peak numbers of cases later in the year, and they had learned from all that earlier activity. So these side effects statistically are giant, and may give the biostatisticians working on the team great challenges, but it's something we're dealing with, and it's also an example of the reality of this pandemic. Harmonizing EHR data across health systems is incredibly challenging. There's the term interoperability, the idea that somehow, at some point, we'll be able to look at data across health systems. It fails in almost every effort to do it. We're doing it across these 21 sites to the best of our ability, but as I mentioned when talked about the variable death, as simple as a variable death, every health system codes death differently. And what it means then is for every variable of interest, every data element of interest, we need to make sure we're capturing it the way every health system codes it. A giant challenge, and we have 220 elements that we're doing this for. Another really important limitation is that we only have data that's limited to the health system where the COVID was diagnosed. So for example, if we have a patient who was admitted to UW Health with COVID, but happened to be living in Milwaukee, we treat that patient for COVID at UW Health. They get through the acute episode, they're discharged, they go back to their home in Milwaukee, they get sick again, they're admitted and they die at the Milwaukee site. We wouldn't capture that in the UW Health data. So it's just frankly a limitation of the data. All of this, of course, is real world de-identified EHR data limitations. So that's the fundamentals, that's the background, that's what we've been doing for a year. I want to share now some of the findings. These findings are preliminary, and really importantly, they're univariate reports. Nothing is controlled for. It's really a very first pass look. Because they're preliminary, I appreciate you not sharing them. I'm going to talk about the whole 21 sites and then zero in on UW Health. So across the whole 21 sites. So how big was our sample? And you're going to see this here. We've got about 625 total patients across the 21 health systems. The health systems contributed anywhere from 4,000 to 79,000 patients. Inpatients, I mentioned, we're going to be really zeroing in on this population, and we're talking about the inpatient encounter when COVID was diagnosed. Here are the 21 systems in their ranges of contributions of patients, ranging from 4,000 to 79,000. I'm going to skip that slide and turn to gender. Here's the first univariate, uncontrolled observation I'll make. In terms of the overall sample, which you'll see on the left, and then the inpatient COVID diagnosis on the right, there are more women overall who were diagnosed with COVID in the sample, but there are more men that were hospitalized, suggesting that possibly men get sicker with COVID than women in this sample without controlling for everything. Univariate analysis, giant caveat. What about age groups? This is a pretty obvious one. If we look at the overall sample, the ranges are across the spectrum. But when we look at the hospitalized patients, it's incredibly skewed to older people, with 47% of the sample among the hospitalized patients over 65, but only 19% of the total sample over 65. What about race in terms of categories? We've got large numbers of lots of races. I'd particularly highlight in the overall sample, we have 85,000 African Americans. This is another signal, again, univariate, that in the overall sample, about 14% were Black, but among the hospitalized patients, 26% were Black. And this is a signal consistent with other reported data that African Americans get sicker with COVID. In terms of Hispanics, the sample is pretty similar between the hospitalized and the unhospitalized between the overall sample and the inpatient sample. But look at this, 100,000 Hispanic patients in the sample. We're going to be able to really do some great analyses on race and ethnicity. Smoking status, of course, of interest to the Center for Tobacco Research and Intervention. The big takeaway I'd say here is the signal is that those who are current or former smokers appear to be more likely to be hospitalized. That signal is particularly strong with former smokers. Again, univariate analyses and not controlled for. We'll look at this in more detail. E-cigarette status, the big point here is missingness, 61% missingness. We're not going to be able to interpret much there. Cancer is an important variable from the funder, the National Cancer Institute. And the early signal is that across the whole sample, we had 7% who had any type of cancer. But among the inpatients, 13% had some type of cancer. Maybe cancer patients get sicker. And I'm not going to go into the comorbid conditions, but as you would expect for virtually all of them, the inpatients were more likely to have these comorbid conditions, consistent with the fact that if you're older, you have more comorbid conditions, you get sicker in general, irrespective of the infectious of other disease. We looked at some of the psychological and as well as alcohol use variables. Not a lot there, but we have a lot of pregnant women who were hospitalized, and that's a topic that we look forward to examining. BMI is a big issue with COVID, and it plays out here. When we look at the overall sample, they're generally overweight or obese, but look at the degree of hospitalized patients that are overweight, obese, or severely obese, a BMI of 40 or greater. It's a giant proportion of the inpatient sample, and that'll be a topic of examination. And then finally, deaths among hospitalized patients. Our analysis is going to focus on deaths as well as death or intubation, expanding the outcome of interest. About 10% of our hospitalized sample died. About 18% of our hospitalized sample either died or was intubated. Medicines are really fascinating in terms of how this is changing over time. When we looked at this data back in the summer, hydroxychloroquine, about 30% of the total of the inpatients had been put in on that. In the more recent months, essentially nobody is going on hydroxychloroquine because the data has suggested that it is not helpful in this disease. And then this last overall slide is number of days hospitalized. An extraordinary proportion of them were a day or fewer. Some of these people died within that, so this includes both those who survived and those who died. But look at the proportion who were hospitalized for greater than 8 days, a third of the patients, and how uncommon it is now to have patients hospitalized for a week or more. Well, a giant proportion of the COVID sample across the nation are staying in-house for long periods of time, and you all at UW know that well. All right, let's dive in now and share some of the UW health data. And really happy to share this, and thank you UW Health for being such an incredible partner in this project. This is the overall slide where we're showing you the real classic epidemic curve of COVID. The blue lines represent total UW health patients in total. There have been, this is now through the end of March, so the UW health data is more recent. All of the overall data that I showed you earlier was only through the end of December. UW health data, though, we've already begun to analyze it through the end of March. And we had 12,000 total COVID patients over the first year of the pandemic at UW Health, and we had 1,100 hospitalizations. And again, a classic epidemic curve. And anybody who's been on the wards know that the worst of it was the fall, October, November, and December. And one thing we're really interested in is the proportion of hospitalizations among the total sample per month. Initially, back in March and April, few patients, but many of them were hospitalized. Since then, somewhere between 5 and 10% of the total UW Health patients end up being hospitalized. I'm going to skip that slide, going to gender, and we see in UW Health the signal we saw across the whole sample, that there are more females diagnosed with COVID, more males hospitalized with COVID. Here, we're looking at age, and again, the expected finding that a broad age range across all of the patients, but we look at those who are hospitalized, the bulk of the patients are over age 35, and a great proportion of them are over age 65. Here is race. We're looking forward to examining this in more detail. And unlike the total sample, where we had 25% of the hospitalized patients African American, here at UW Health, about 4.5% were African American, but a slightly greater proportion than the total sample end up being hospitalized. We'll look at that in some more detail. Not much of a signal with Hispanics, other than a bit more of them were hospitalized than the overall sample. We're very interested in insurance, and this shows the range across the whole 12,000 UW Health patients of the insurance status of those patients. Not surprisingly, given the population of Dane County, the bulk of them were commercial. But when we looked at the hospitalized patients, we examined the deaths based upon insurance status. There's some interesting signals. First, here are the Medicare older insurance individuals. About 12% of them who were hospitalized ended up dying versus 7% of those with commercial insurance. Look at this, it's just few patients here, so it's not a strong signal. But among the uninsured, 24% of them died when hospitalized. Smoking status, a variable of great interest to us, and here is looking at the outcome being death and or intubation. Among current smokers, 25% of them ended up either dying or having intubation or being intubated. Not a much of a signal between former and never smokers. So the UW Health data is giving us a univariate signal around current smoking being associated with death. This is cancer, and we don't see a difference at UW Health in terms of death or intubation rate based on cancer status. Here is looking at BMI, a really powerful signal that the underweight people actually did not do particularly well in terms of death or intubation. 24% of them had that outcome, but a pretty linear relationship between going from healthy weight to severely obese. The greater your weight, the greater the likelihood among the hospitalized patients of either dying or being intubated. I'm going to skip that slide, and I'm going to bring us back to the epidemic curve that shows the peak through October, November, and December, both for total patients as well as hospitalized patients. And now finally looking at the total number of deaths at UW Health. This total number of deaths among the 12,000 total patients have been 304, and it exactly mirrors the epidemic curve we saw earlier, with about a 1-month delay, which is not surprising given the nature of this disease. And finally, I believe this is the last data slide, showing the rates of death based upon month. The earliest month of the epidemic, 24% of the patients hospitalized died or were intubated. Since then, the rate has been pretty steady between about 5 and 10% of hospitalized patients at UW Health dying. I'm just going to turn now, I'm done with the data slides. I'm going to talk about some of the research questions that we're asking with these data. We're looking forward to developing a specially informative algorithm to predict COVID severity and outcomes. What predictors are especially important in assessing outcomes and progression among the full sample, as well as the subsamples, the inpatients, the ED patients, etc. Julie Kirsch, one of our postdocs, is going to be looking at the issue of what predicts hospital readmission, what predicts the use of various medications. Has COVID-19 treatment changed over time? This is an unusually powerful sample to look at that, and we will. Brian Williams, an assistant professor in the department, will be looking at children, youth, and young adults. And we're very interested in examining how COVID has evolved over the years. So next step, over the 2 years of the pandemic. We're expanding in 2021. All 21 sites have agreed to continue to participate. We're doing tons of paperwork, and I would just a shout out to Karen Connor and Rob Adsit, who have managed this study expertly over the 2 years of it. We're going to be moving from a de-identified to a limited data set, and I've already described the power of that change. We've added key data elements that I highlighted. We're going to go back to February 1st, 2020 for all of the 625 so that we get zip code data, we get diagnoses data, etc. We get data, treatment data. We're going to continue to collaborate with NCI and the other giant cohort that exists. And ultimately, the data late in 2021 is going to be transferred to NCI, and it will be available for public access. And our next step is we've got to publish. We've collected a ton of data, and we're in the process of preparing about a dozen publications on it, but none have been published yet. Ending now with some real world trials and tribulations. EHR data is messy, it's incomplete, and it's not collected similarly across clinicians and across clinics and across health systems. The chaos of the pandemic just made that even worse, and we're trying to clean up that chaos. We've had to be flexible, we've had to be iterative, and we've had to be opportunistic, and we've done that every step of the way. I mentioned this issue of heterogeneity. The way health systems code things is not a pretty picture, and we've had to try to make sense of that. Harmonizing data, as I've emphasized, a giant challenge, and thank you to the team and the individual, Stephen Smith, who oversees data analysis at the Center for Tobacco Research and Intervention. His hair over the last year is turned much grayer as a result of working on this project. Thank you, Stevens, for all of your work. On the tribulations, it's incredible the degree to which individuals have stepped up to contribute to the project. And I want to say the health systems, in the middle of the chaos of treating COVID and the demands on their IT and other teams, have said we want to participate, and I'm so grateful to them. And then finally, the team that we've pulled together, it numbers well over 30. It's been a labor of love and contribution and sacrifice, and to all of them, I say thank you. So I'm going to end there, but before I take questions, I just wanted to make one last point, and that is Lynn was very generous with her introduction of me at the top of the lecture. This July 1st, I'll be celebrating my 33rd year on the faculty in the Department of Medicine. Next year, the Center for Tobacco Research and Intervention will be celebrating its 30th anniversary of its founding in 1992. All of this has been possible because of the extraordinary environment of the University of Wisconsin, and in particular, the environment of the Department of Medicine. I've found this place to be an incredibly effective mix of support, but freedom, and the support when we need it, and the freedom to be entrepreneurial, to be scientific, to be innovative. I've loved being in the Department of Medicine. I love that the Department of Medicine has provided academic homes for our scientists and the new scientists that are coming on the scene through CTRI. To all of my colleagues in the department, thank you for listening in, and I'm honored to join you in our collective efforts as a Department of Medical School and a university. Lynn, I'm turning it back over to you.
Great, thank you. I mean, listening to what needed to happen to make this fully realized, it's just an incredible lift. So again, kudos to you and the entire team, both here and throughout the nation, for doing this. It's an incredibly rich data set. And one question I had is, while you mentioned it's going to be going to NCI for public access, is there an opportunity for folks here, for example, if there's some specific question that they're interested in querying, to be able to do some smaller projects on this data set? What are your thoughts on that?
Absolutely. And we already have a bunch of folks in the department that are working on it, and it's been wonderful to have them a part of it. Every data set has to be produced for analysis. If you get the whole shebang, the raw data, it really would be essentially impossible for everyone to deal with. But one thing that we're aiming to do is to be responsive with the first opportunities to analyze data going to those who've been preparing it. But we would, of course, welcome other departmental colleagues who have focused questions. Our biggest limitation, frankly, is preparing the data sets. It's a giant lift for each one of them, but it's something that we are for sure open to. And I think it's one of the reasons, why UW was asked to do this, because of our collaborative nature.
Yeah, well, there's a number of questions, and I will try to get to as many as possible. One question that came up in terms of the obesity data that you shared, while we don't have a control in this cohort, do you know, is the percentage of patients who presented with COVID and the percentage with the obese, severely obese, et cetera, does that match what is known in nationally?
Generally, yes. We have seen that overweight, obese, and severely obese people are much more likely to have adverse complications when they develop COVID. One thing this data set will do that few others have done in the past, because it has data across 21 systems, it's going to be able to address the site difference issue. That's a benefit and a risk statistically, but we won't have the problem that a specific site is limited to just looking at data within that health system.
One question that came up was the tactic of combining death and intubation. And since particularly early in the pandemic, there was a big push for early intubation of patients, whereas that practice has changed. And will you be able to tease that out in your data set?
Yes, we'll be able to tease that out in two ways. First, we'll examine death by itself, which is obviously the most important outcome of interest. But we'll also examine, because we've moved to a limited data set and we have the date of the admission and the treatment, we'll be able to examine rates of intubation over time and if they're associated with other key outcomes.
Great. And are you capturing any information on the cost of care?
Not explicitly. We're not capturing billing data for the individuals. One could estimate certain aspects, like what it costs to be in an ICU, what it costs for a day to be intubated, but those would be surrogates rather than actual costs.
And in your data set, are you capturing thromboembolic events? And if so, do you have an idea of the prevalence in this population?
What we're capturing is the diagnosis of hypercoagulability. So if it is diagnosed, we will capture that. We're not capturing lab data, for example, on PEs, lab results, or lower extremity
The DVTs.
robotic events. But we do have hypercoagulability as a diagnosis that we're capturing. We have not yet looked at those data.
Great. And are you including antibiotics? Are you capturing that information as part of your medication?
We have targeted antimicrobials, particularly as they relate to the viral antimicrobials. We don't capture all antibiotics, no.
Okay. And are you capturing any measures of oxygenation?
Yes, we are. Both the amount of oxygen, but also the way it was administered.
Great. And then I will ask the final question. Having gone through this, what would you do differently in the next pandemic?
Wow.
What lessons did you learn?
Well, this is a systemic challenge, and that is the way data is captured in the electronic health record is it's a giant step forward from the days 30 years ago when we were writing everything down, but it's still incredibly messy, incredibly incomplete, incredibly difficult to harmonize. At the federal level, the Office of the National Coordinator is working on standardization of data collection. They're working with the major vendors. It's a noble goal, but boy, is it a giant lift.
Great. Well, with that, we are out of time. I want to thank you for both an amazing career and a great talk. And we look forward to seeing many publications coming out of this and increasing our understanding of COVID and how we can improve our care of our patients. So thank you again. Thank you, everyone, and enjoy the weekend.
Thanks, Lynn.